I'll be brief. Great. So I think Cascades as an initiative is really motivated by the need to engage the healthcare community in climate action and awareness. And climate change is not the only challenge facing the global community or us locally by any stretch of the imagination, but it is certainly an issue that warrants attention. And it's been hard to ignore in some ways, although arguably it has been, because we're going through the 6th assessment process for the Intergovernmental Panel on Climate Change, and there's been these 3 reports. Those are the images on the left, the one looking at the physical science basis last summer, and then this year, in February, and then more recently, looking for issues of impacts, adaptation and vulnerability, and then questions of mitigation. The image I have here on the right is an image from the first one, the one from the physical science basis, which just shows us very, very definitively, as the science has gotten yet more accurate, that climate change is human caused. So if we can just move forward, advance the slide. That if this were caused by natural variability in our climate systems, we would expect to see a line like this. But in fact, if we can move forward, what we are seeing is a line like this, and a really astonishing rise in global mean temperature. We're at about 1.2 degrees Celsius global mean temperature increase, and the climate models suggest that we will be at 1.5 by about 2040, at which point the climate models diverge. And that's really a function of what we do now in terms of reducing greenhouse gas emissions, but of course, quite a bit is baked in, and Canada is warming at twice the global average. So if we move ahead, this context is really a challenge for health systems. There's first this question of how do we react? The images on the left are from British Columbia. Our colleagues there are well aware that they were sorely tested last year with climate-related extreme weather events. First, the heat dome, very, very intense heat in the summer. Over 600 people, I think, was the latest review and analysis of the, even in a very short period of time, the immediate health effects of that extreme temperature, hitting almost 50 degrees Celsius in Lytton, British Columbia. And then in the fall, the atmospheric river, creating significant infrastructure damage. So what this means then, if we move forward, is that we know that climate change affects health, and there are acute shocks which increase demand. There were many, many people needing care for heat-related illnesses in the summer. And at the same time, moving forward, the capacity of the system is reduced in the context of these kinds of shocks. So it's very hard for dialysis patients to get their care, for many patients to get access to their medications, to surgery, to other treatments, to primary care visits. Even as it can be significantly increased demand. And of course, moving forward, these aren't just acute shocks, they accumulate, they compound, and there are chronic stresses for individuals and communities that are particularly vulnerable in the face of these challenges or lack the resources because of structural disadvantage to actually meet the challenge as well as they could and recover from. So mental health challenges, cardiorespiratory illnesses that are associated with all of these issues. And at the same time, moving forward, please, these chronic stresses challenge our operations, again, the workforce, the facilities, our supply chains, our capacity to do this work. So the first sort of challenges we know of climate change is the fact that our health systems and their continued high quality operation is risked, and we need to address that. Moving forward, the flip side, of course, is that the health system itself poses challenges for the climate. And an image on the left that some of you will have seen that is one of my most both glorious and sort of painful is from Dutch spatial artist Marie Koik, and it's the image from her surgery and anesthesia. And as we look at this image, what we see is not just those immediate products that are waste after her surgery, but all of the resources and all of the energy that is embedded in resource extraction, in manufacturing, in transportation, in use, and yes, in disposal. But that whole life cycle of emissions and of resource extraction is what makes healthcare such an incredibly resource intensive and highly polluting service sector. And indeed, the image on the right, which is from the Lancet Countdown, the 2021 version, is showing us this climate intensity of healthcare systems, but also showing us that this varies across the world. The most climate intensive ones are in the rich world. The US is the most carbon intensive. Canada, according to 2021 data, was the second worst. And then the rest of the world that much less climate intensive. So a couple of lessons from this, I think, are one. We know that some of this climate intensity is due to inappropriate care, low value care. We know that some of the rest of the world, the majority world, low carbon intensity of care is due to innovations in the delivery of care, like the Aravind Eye Clinic, that are innovations in high quality, low carbon care that we need to use. But we also know that there's a lot of served populations, including in places like Canada and certainly around the world. And so as a community, we need to grow access to high quality healthcare while shrinking its climate footprint. So moving forward, I guess this statistic, again, from the Lancet Countdown, almost 5% of global emissions are estimated to be from healthcare. And I think my final slide is just that, as many of you know, we're approaching these challenges at a time that is very challenging, but also, I think, quite hopeful, that momentum is building and the growing recognition that health and health systems are a critical part of our efforts to transition to a more sustainable world. So what I'm showing you here are images from the COP26 health program convened by the World Health Organization and the UK presidency of the last climate change conference, UN climate conference, that was in November, largely November of last year, COP26, where there was a call for countries to commit to delivering climate resilient, low carbon and sustainable health systems. Canada at that time signed on, as did the US and many other countries. I think there's about 59 countries that have since then signed on. We expect in COP27 in Egypt to see an intensification of attention to this and growing effort to get countries to identify a timeframe to deliver climate resilient, low carbon and sustainable health systems. It's very important for us as Cascades, moving on, because of who we are and how we're funded and how we operate. So we are in fact a grant from Environment and Climate Change Canada, and really a community engagement grant. This is not research for us. This is really about supporting excellence and innovation that's happening around the country and trying to help coordinate and promote that. We are an initiative of 4 organizations: the Center for Sustainable Health Systems at U of T, the Healthy Populations Institute at Dalhousie University, the Planetary Healthcare Lab at UBC, and a national NGO that's been in this space for over 20 years, which is the Canadian Coalition for Green Healthcare. And we operate across the country with regional leads in central Canada, in Quebec, in Eastern Canada, and in Western Canada. Moving on. And what we're doing then, or hoping to do is, as I say, is to identify and work with, collaborate with, support, and catalyze the excellence and the expertise that exists around the country and has for a long time through these 3 kind of pillars of activity. Focusing on the ones on the outside, we're really trying to leverage and build knowledge, skills, and networks. We do a lot of continuing professional development. On the right, we see a growing role, given the federal government's commitment, to help coordinate and be a national voice for low carbon, in particular sustainable care. There is, I think, significant capacity in Health Canada for climate resilient health systems, but less so for low carbon sustainable. So we see a role for ourselves there. And then what we're here today on is really support for innovation, really drawing from a quality improvement methodology and mindset to select and support sustainable healthcare innovations through local or regional tests of change or national spread. And I think that's my last slide, and moves us over to the case of sustainable inhalers that Samantha Green will talk about. Thanks so much.
Great. We can go on to the next slide. So the reason we focused in on inhalers as kind of the first spread project is because they are a hotspot in the healthcare system for emissions. This graphic is one way of illustrating the problem. 100-meter dose inhaler doses are equivalent to driving, on average, 290 kilometers by car. the NHS in the UK estimated that metered-dose inhalers were responsible for 3.1% of their health system's total emissions. So it's kind of low-hanging fruit, something that we can really intervene on and make a big difference. Next slide. So there's two ways that we can think about making a difference. And the first is, I guess, two main ways. The first is really thinking about, do patients who have been prescribed inhalers really need them? It's been estimated, this is from Choosing Wisely Canada, and some studies that they've cited, but it's been estimated that a third of patients labeled with asthma do not have asthma on objective testing, and most of those patients have been prescribed an inhaler. So one way that we can intervene is to make sure that, if a patient hasn't undergone objective testing with spirometry, that we make sure that they do. There are also many instances where inhalers are prescribed without a diagnosis for things that they're not indicated for example, acute viral cough or post-viral cough. So next slide. So this is a recommendation from Choosing Wisely Canada that basically everyone over age 6 should have objective testing done before prescription is given for the treatment of asthma. And this is actually just showing the updated GINA guidelines, and you can actually go on to the next slide because it's very similar. So this is the updated Canadian Thoracic Society guideline which was just updated last year, around the management of asthma. And so there's also this opportunity for providing better, more up-to-date care while thinking about switching our patients' inhalers away from metered-dose inhalers. So as you may be aware, the updated guidelines based on the 2 Sigma studies say that even those with mild asthma, very mild asthma, benefit from prescribing budesonide, formoterol, or Symbicort to be used PRN as a controller and reliever, or for very mild asthma just as a reliever. So there is an opportunity here as we're trying to update the care that we provide to our patients, as we're kind of reviewing the patients in our practices who are prescribed inhalers. We need to review whether they actually have an indication, and then we need to review whether actually the management of their asthma is up to date. And we can think about, if we're switching someone from, say, for example, salbutamol PRN, we may want to discuss the benefits of switching to a PRN Symbicort instead. Next slide. And this just is illustrating the disproportionate carbon impact, the carbon emissions from metered-dose inhalers versus soft mist inhalers, which really in Canada is just Respimat, or dry powdered inhalers. And there's a number of different examples there. So as you can see, dry powdered inhalers have a much lower impact on emissions. Next slide. So, I mean, what I think we are advocating for is switching patients where appropriate from metered dose inhalers to dry powdered inhalers. But the where appropriate is, of course, key. It's interesting when we look at the data, the prescribing data overall here in Canada, about 30% of inhalers prescribed are DPIs, 70% are MDIs, but it's actually the reverse in Europe. So there's certainly room for us to make a shift towards DPIs. Now, MDIs with spacers are still indicated for preschoolers and those with poor inspiratory flow, also those with dementia who may not be able to sync their breathing. But the vast majority of our patients do better, actually, with dry powdered inhalers, including school-aged kids. They're actually preferred for school-aged kids. They're also preferred because they have a dose counter. You may be aware, but salbutamol does not have a dose counter. So often patients don't know whether their blue inhaler is empty, and they may be using an empty inhaler, or they may be discarding an inhaler before it's run out. Next slide. And this is just illustrating the huge difference that we can make if we were to switch a patient on average, from a meter dose inhaler to a dry powdered inhaler, it's almost equivalent to switching from a gas-powered to a hybrid car or from a meat-based to a plant-based diet. Next slide. So we've been working on this here in Toronto for about a year now, building on the work of the Sustainable Health System Community of Practice, which is a collaboration between the Toronto Academic Health Sciences Network, so the network of all the academic hospitals in the GTA, and the University of Toronto's Council of Health Sciences. And so the Sustainable Inhaler Prescribing was chosen as one of the pillars of that initiative about a year ago. And what we've been doing is creating tools that primary care providers can use to improve their inhaler prescribing. And we also delivered a number of webinars over the last year. Yes, these are the tools that we have created. I think I'm going to hand it over to Nicole to take it from here. Yeah.
Great, thank you. And I'll just...
Yeah, maybe I'll just say, so these tools are currently undergoing review by our National Advisory Committee, and we are improving them. We also actually had a couple of patient panels review some of the tools. So we will have these new and improved tools ready and available for this initiative, this national spread initiative. But these are the tools that we used in Toronto. So a number of posters that people can put up in their waiting rooms, a letter that can be sent to patients when you receive a prescription renewal request, and then actually a number of reference charts kind of illustrating appropriate switches. For example, from salbutamol to terbutaline, or from salbutamol to Symbicort.
Great.
Right. Yes, I'll hand it over.
Thank you. And I'll just note that we do have a playbook coming soon that sort of describes each of these resources, offers implementation guidelines, provides links to the resources. So we look at this as kind of version 1, but as Dr. Green said, we have been reviewing these assets with the National Advisory Committee, and Ernest will talk more about what this committee is all about in just a moment. But the objective is to really sort of make sure that these resources meet the needs of providers and teams from across the country who are looking to affect the more sustainable inhaler prescribing. So stay tuned for our playbook, but it's version 1. Version 2 will emerge sort of with the collaborative as we kind of test the spread and we refine our assets. So I will turn things over to Ernest to talk a little bit about the model that is informing the collaborative.
Great, thanks very much, Nicole, and hi everyone. It's a pleasure and honor to be speaking with you today. Just wanted to talk a little bit about the format for our learning collaborative for you to consider joining, and what it might be like, feel like, and the value and benefits of being part of a collaborative on a common topic, such as the use of inhalers across the country. So what this model comes from is from the Institute for Healthcare Improvement, or IHI. It's a global healthcare improvement organization based out of the US. Some of the Cascade staff and I were very fortunate to attend a program to learn about the learning collaborative model that's been in practice and use for over a decade now. So back to 2006 is when they first started learning collaborative. And it's based on the idea that when a best practice or works in one area or region, be it pertaining to safety, identification of patients, or moving a discharge of patients in hospitals to sooner, or improving the mobility of patients, that we can spread best practice, even in educational settings, a best practice for educating or precepting nurses, for example. The learning collaborative is an improvement method that relies on spread and adaptation of something that works well in one spot and sharing or spreading it across other regions of similar contexts. So the next slide has a visual of how we're planning to apply this model to the use of inhalers for primary care. We've selected the topic because of interest that we've kind of gleaned from you all, for people who want to get interested in it, who see the value of thinking about healthcare and our impact on the environment and how well we're positioned to do something about it, and the trusted role that physicians have in society. So we've developed a charter which frames the issue. What we're trying to do is to improve the use of sustainable inhalers. It frames the topic, it frames the data, it frames the goal. And we've put together an expert panel of a national membership or a committee, and we've been convening to figure out, well, what can go into, how can we best support teams across the country? Well, there will be, as Nicole mentioned, a playbook that organizes what are called change ideas, such things like switching a formulary or having education programs. And we are going to introduce this playbook to teams who are part of the collaborative through the first learning session. And in that learning session, we'll talk about the model for improvement that comes from IHI, the quality improvement model, which is essentially plan, do, study, act, which I'm guessing some of you have seen before. So if we're going to plan to switch a formulary, what can that look like? When will we implement it, which is the do? And what are some measures we're going to be able to study to look at effectiveness and see what works in our context or not. And that's the act. So act to accept, adapt, or abandon some of the changes that are being developed and will be referenced in the playbook. We know that not every context, region, municipality, patient population is the same. So where one thing may likely work in one spot, it might look a little bit different in another. And we can benefit from having a collaborative, a national collaborative, to learn what works in one area, what can we approach differently in another, how can we approach common challenges together? Like I noticed in the chat a little bit of how do we talk to government or elected officials to talk about the formulary? What are some strategies and approaches? How can we band together to make an impact and change? Throughout the learning sessions are 2 hours each. What's interesting is the IHI recommended that the learning sessions be longer, but we feel that in such a community, we can be able to collaborate virtually. So in the first session, we'll talk about the model for improvement, what plan, do, study, act is, provides things like a run chart to measure our data, which measures change over time. In the second session, we'll talk about QI tools that will help you and teams work together, including the charter. And in the third session, we'll talk about what are some systemic changes and barriers that we've approached, and how can we make some recommendation via reports or publications or policy changes. We hope that this model works for use of inhalers or climate conscious inhalers, and that it can go forward and be offered again in the future for more and more teams across the country to join, and for other topics that are particularly relevant and have a high impact in sustainable healthcare. So this is the spread model that we're leveraging from the IHI, is adapted to Canada and as put together through Cascades. The thing I didn't mention in the corner is there are supports between each of the learning sessions, which are referred to as action periods, via email, coaching calls, assessments, phone conferences, and essentially building a community of practice across the country. Welcome any questions that people may have about this model. We're excited about it. It's going to be the first time we're putting it together. It's going to start in August. I'm sure we'll learn some things as we go forward. And I think we're already off to a good start. We have at least 5 applicants to the collaborative, and we hope that more of you will consider applying as well. It benefits when you join as a team, so more than an individual, but if you can join as a team. I know that can be hard, but we really hope that you will join as a team. Yeah, so that's our learning collaborative model. I think I've said a good amount on this. I'll just sort of check the chat to see if there's any questions. Nicole, would you like to add anything to that summary?
I will go through a few more logistics in just a few more minutes. So I think let's see what I get to, and then if we have anything to kind of add at the end, or if anything comes up in the questions, then we'll address it there. But thank you. I did just want to briefly go over the members of our National Advisory Committee, just to give you a sense of, we've really made an effort to have representation from across the country, because we realize that there are some provincially specific concerns that we might need to take into account. Certainly when it comes to coverage for different types of inhalers, we're certainly taking that into account. We've made some charts that indicate coverage in the different provinces. So just to give you a sense, and as Samantha mentioned, we have had a group of, we had a few focus groups with patient partners, and a few of the patients who participated in those focus groups have joined our national committee. So we do have some representation from the patient side as well. And so you can see we have some pharmacists, nurses, prescribers, etc. So I want to kind of zip over some details about what you can expect at the collaborative. I'm going to kind of gloss over this again, just trying to give you a sense of what participation will entail. This is still in the process of being formulated, so we are working on this summer so that we will be ready to go in September. We, of course, welcome your feedback as we move along, but I'm going to talk about that change package that we've touched on. So this is a more enhanced version of the resources that were completed in association with the project that Dr. Green described. So the objective of the change package is really to provide primary care providers and leaders with tools and resources to facilitate sustainable inhaler prescribing. And really the value, one of the big draws, I think, of participating in the collaborative is that we can support the adaptation of those tools or the development of new tools as we move forward, as teams perhaps identify gaps in what's provided or possible improvements. So we have 4 different change categories. So these are 4 different areas of interventions. There's prescribing appropriately, encouraging alternatives, and Dr. Green already went over these 2 sort of main change categories. There's also reviewing technique and encouraging appropriate disposal. And for most of these categories, we've grouped our resources into 3 distinct categories. There's provider education, there's patient education and communication, and there are prescribing tools. So we basically see this as a kind of sustainability pathway. So we are looking to apply a sustainability lens along the care pathway, and we can make interventions, like I said, in those 4 different areas, right? When it comes to need, to type, to technique, to disposal. So in the very first instance, does the patient actually need an inhaler? Let's establish that. If so, is it possible for them to switch to a more sustainable alternative? And regardless of which kind of inhaler they're using, let's make sure that they're using it right, so that they're not wasting medication, so that they're not throwing away half-used inhalers if possible, and of course, so that they're getting the benefits of their medication. And again, regardless of the type of inhaler they're using, let's make sure that they're disposing of it as appropriately and as sustainably as possible. So we do have a series of tools and resources that we've developed just around providing background content on climate conscious inhaler prescribing. And those consist of our primer, we have an infographic, the webinar that Dr. Green mentioned is available online. We have a sustainable inhaler pathway guide, essentially this guide that we're working on. So those things exist sort of in the background. Those are tools that are resources that you can consult to provide context. But then in each of these major categories, we have other tools that we've been assembling or developing. And I'm not going to go over all of these, but you can see that there is the kind of major category, those 4 categories, a description basically of what that category is all about. What are some possible interventions that you can make when it comes to new prescriptions or existing prescriptions? And what are the tools that can facilitate those interventions? And so the change package will include all of these tools. So it will have a description of these tools, it will have implementation guidance, and links to the tools themselves. So we are still in the process of getting all of these things together. But for example, when it comes to encouraging alternatives, when it comes to new prescriptions, the intervention is to default to dry powder inhalers for eligible patients. When it comes to existing prescriptions, we should be educating patients about the opportunity to switch. We could be proposing the switch at renewal. We could be proposing the switch during an unrelated visit. And if a switch is inappropriate, we can be kind of monitoring the situation. If circumstances change, then we can jump to, looking into some of those existing prescription interventions. Some of the tools that we've got, or that we're putting together, posters that you can put up in your waiting room or send out in a newsletter, a patient-facing infographic, an inhaler chart with links to instructional videos so patients can spend some time looking at, what the different inhalers look like, how they work, seeing what they feel comfortable with. We have an email that can go out to patients upon if they go in to get a renewal of their prescription, to just inform them about alternatives. We've been talking a little bit about possibly creating a video featuring patients who have switched. This is still a possibility. This isn't something that we've got right now, but again, these are the kinds of assets that we can, invest in as the collaborative advances if we really see a need for them. On the provider education side, we have inhaler alternative charts that show you the carbon and coverage comparisons between different inhalers, and those are provincially specific for the coverage. And then on the prescribing side, there is that email to patients. There's a letter that a pharmacist can send to the doctor. If a patient comes into the pharmacy asking to renew their prescription, the pharmacist can get in touch with the provider and ask them about a more sustainable prescription. There are modifications to EMR, and we're looking into getting a list of vendors that could provide samples and potentially providing an actual kit. So just gives you a sense of the kinds of resources that we're putting together. Ernest, I see your hand up there. Oh, you're on mute.
Thanks very much, Nicole. I wanted to mention that in the learning session one of the things we'll be going over is understanding the patient's journey and the process from the patient's perspective. And I mentioned that every region is similar and different, and there may be similar process steps, but the patients may experience things a little bit differently depending on your region. So this change package and these change ideas are change ideas that may work. Not all of them might not all apply to your context, but some of them may apply more than others. So we hope to learn which ones have the highest impact and make sense for different regions through the patient's perspective on the process that you use in your areas. So just wanted to center that a little bit on connecting to a QI tool, and also the importance of the patient's perspective and understanding the process. So yeah, sorry, a little commercial break there for learning session one.
And you will hear from a faculty at the collaborative who have implemented these ideas or similar tools to get their perspective on what works best, what doesn't work as well. And again, that feedback has been informing our National Advisory Committee vetting of these resources. So we have been working to improve them based on experiences from the field. Not going to go over this too much, but we will be keeping track of metrics within the collaborative. So we will provide a measurement strategy. We are going to try to make this as easy as possible for teams. We know that people are pressed for time. We are likely only going to be collecting metrics around those first two areas of change, so prescribing appropriately and encouraging alternatives. We'll keep track of a few process measures and a few outcome measures. We will provide you with a run chart template that makes it really easy for you to just enter information. It will generate charts for you. Our objective is to make this feasible for teams. So in terms of logistics, also going to zip through this section, as Ernest has already covered quite a bit of this. So our first learning session is going to be in September. We are still finalizing the dates, but there will be a little bit of pre-work that teams will need to do before that first session. And it's really just like reviewing a little bit of content and collecting some baseline data related to those outcome measures. But we will be very clear about what is needed, and we will again try to make it as feasible as possible for teams to do. Between the learning sessions, there is a status update form that teams will need to complete once a month. This will just be a form on REDCap again, trying to make this very easy, just with a kind of a quick check-in to see where teams are at. They can report on any progress in their metrics. They can let us know of any sort of challenges that they're facing or any kind of enablers that they found, things that are really helping them to succeed. We are hoping to do Zoom check-ins with all of the teams, just quick calls where, based on the status update forms that come in, we can kind of showcase, you know, if one team is having a lot of success, we can kind of feature what they're doing, ask them about it. They can share a bit with the teams, just so that we can stay connected as a community as we move forward and really learn from each other's challenges and successes. So you've got the 3 learning sessions with some check-ins in between. And then we are hoping to have a public showcase at the end of March, where we can kind of open it up and just have an hour-long session to just, if for anyone who's interested, we can kind of communicate how things went, you know, with the actual interventions, but also with the learning collaborative model itself. So this is the first time that we're doing this. We're so excited, and it'll be so interesting to see how this unfolds as a mechanism for spreading sustainable practice change. So for who should join, if you're from a primary care setting or involved in a primary care setting, so patients could be part of a team, for example, they should join. People do need to be willing to share their story. We may have a collaboration agreement. There will be a charter that kind of describes the collaborative, and teams will be asked to sign that. And they'll need to be able to commit to those sessions, and we will nail down the dates in advance before we ask you to commit. Ideally, as Erna said, you're a team, you're a multidisciplinary team. You've got embedded QI and measurement capacity, although we are, again, going to make things as easy as possible if you don't have that capacity. And if necessary, you know, if you need commitment from your organization or permission, we would like to see that somehow. Not everyone will need that. I think Ernest already went over the agendas for the change sessions. Really, the key thing is during the first session, we're going to be learning the change package together, and the subsequent sessions are really about, you know, working through how it's going, talking about any potential adaptations that need to be made, and talking about embedding the practice change. We are in the process of getting accreditation for the learning sessions, and NABA is on top of this. So we are hoping to get accreditation for 3 credits per hour from CFPC, and a certificate of completion will be provided at the end of the learning sessions, and non-physicians can potentially self-report continuing professional development credits. So that's it. The application form is available online on our website. It's pretty short. We're not expecting people to come to this with, you know, some of you, when you filled out that poll, you don't have any background in sustainable healthcare, sustainable health systems. That's completely fine. You do not need that. If you have that, amazing. If not, we are going to work through this together. We're going to figure out the best way to implement sustainable practice change in various settings across the country. And so if you are interested, I do encourage you to apply. I am going to stop there so that we have time to address questions. I see